Chapter 23, Neurocognitive Disorders. In our first case study, a woman brings her mother to your clinic, concerned that her 85-year-old mother may have dementia. "I'm Ellen," she says when you enter. "This is my mother, Veronica. She's not much of a talker these days, so I've come with her to help her express a few things we're both a bit worried about." "Right now," Ellen says, "we're pretty sure she has either delirium or dementia. Maybe. What's the difference between the two?" We'll start off with that question with delirium. Looking at the bigger clinical picture, delirium is a disturbance in attention. It has an abrupt onset with periods of lucidity, also characterized by disorganized thinking, disorientation, anxiety and agitation, poor recall, and delusions and hallucinations. Delirium is a medical emergency that requires immediate attention to prevent irreversible or serious damage. Delirium is a common complication of hospitalization, with 10% to 30% of the general medical patients, and up to 60% in older, frail patients. 20% to 80%, 20% to 84% of critically ill patients. It has a multifactorial psychological causes, such as a cognitive impairment, immobilization, psychoactive medications, dehydration, infection, sleep deprivation, and vision and hearing impairment. Ellen continues, "Well, it's mostly a problem with memory that started maybe 2 years ago. 1.5, maybe? You ask, did something abrupt set this off?" "No," Ellen says. "Mom, do you think some event may have triggered all this?" Veronica shakes her head. "Does she have abrupt moments of lucidity, you ask?" "Not really." Ellen shakes her head. "She's pretty much like this all the time." For our first audience response question, what is an indication that Veronica does not have delirium? A, she seems confused. B, she gets anxious and agitated. C, she seems disorganized in her thoughts. Or D, her problems with memory have been developing gradually. And that answer here is D, her problems with memory have been developing gradually. Delirium has an abrupt onset, while Veronica's problems with memory have been developing gradually. Delirium also has moments of lucidity. Veronica's daughter has seen no evidence of that, but rather a steady state. Both delirium and dementia patients can exhibit signs of confusion, anxiety, agitation, and disorganized thoughts. For our overall assessment, we want to look at both cognitive and perceptual disturbances, including illusions, hallucinations, the patient's physical needs, moods and physical behaviors, as well as their own self-assessment. As far as assessment guidelines, do not assume confusion is dementia in the older patient. Assess for acute onset and fluctuating levels of awareness. Assess the person's ability to attend to the immediate environment. Establish usual level of cognition plus past cognitive impairment. Identify disturbances in physiologic status. Assess vital signs, level of consciousness, and neurological signs. Assess for potential for injury. Assess for availability of immediate medical intervention to help prevent irreversible brain damage, and monitor situational factors that worsen or improve symptoms. Our nursing diagnoses for this patient could take a lot of different angles, everything from risk for injury, altered perception, hallucinations, disorientation, restlessness, fear, agitation, or acute confusion. It may even include things like impaired fluid intake, fluid volume deficit, impaired sleep, impaired verbal communication, self-care deficits, or impaired social interaction. For our outcomes criteria, we want to make sure that the patient will remain safe and free from injury or falls. During periods of clarity, the patient will be oriented to time, place, and person, possibly with aids. Also ensure fluid balance and adequate nutrition are maintained, along with the patient being comforted by a quiet, calm environment. We also, when planning, want to ensure necessary aids and supportive home care team. We also want visual cues in the environment to help the patient remain oriented, and also try to provide a continuity of care whenever possible. While keeping the same staff every day may not always be possible, we want to keep as much consistency as we can. For implementation, we want to prevent physical harm due to confusion, aggression, or fluid and electrolyte imbalance. We also want to minimize the use of restraints, which cause increased confusion. assist the patient with identification and the treatment of the cause, the underlying causes, and use supportive measures to relieve distress. We also want to carefully evaluate this patient, ensure that they remain safe, oriented to time, place, and situation, and are aware of where they are at and why they're being treated. Moving on to mild and major neurocognitive disorders. There's many major and minor neurocognitive disorders, and these are characterized by a progressive deterioration of cognitive functioning and global impairment of intellect. Dementia. Also move on to no change in consciousness, difficulty with memory, problem solving, and complex attention. In mild cases, it does not interfere with their activities of daily living and does not necessarily progress. And in major cases, it massively interferes with their daily functioning. The DSM-5's criteria for mild neurocognitive disorder would include evidence of modest cognitive decline from previous level of performance in one or more cognitive domains. Cognitive deficits do not interfere with independence in everyday activities. These cognitive deficits do not occur exclusively in the context of delirium, and the cognitive deficits are not caused by another mental disorder. These cognitive domains are complex attention, executive function, learning and memory, language, perceptual, motor, or social cognition. Ellen describes Veronica's problem further. She has trouble remembering things like where she put the electric bill. I helped her find it and I thought that was that. But then the next week I picked her up for a lunch date and she looked really nice. No problem with that, she was all ready to go. But her house was freezing. I said, "Mom, did you pay your electric bill?" She just stared at me. There are a lot of major neurocognitive disorders as well. Everything from Alzheimer's disease, frontotemporal lobar degeneration, Lewy body disease, Parkinson's disease with progression, traumatic brain injuries, and cerebrovascular disease. First, let's talk about Alzheimer's disease. When dealing with Alzheimer's disease, it's important to distinguish between normal forgetfulness and memory deficits in dementia. Within dementia, this memory loss interferes with the activities of daily living. And that Alzheimer's disease can progress in severity, going from mild to moderate to severe. Some of the major symptoms of Alzheimer's disease include memory impairment, disturbances in executive functioning, aphasia, meaning that loss of language ability, apraxia, the loss of purposeful movement, and agnosia, the loss of sensory ability to recognize objects. The epidemiology and risk factors, it's the most common is the late onset and female. For biological factors are a combination of everything from genetics, cardiovascular disease, head injuries, and other traumas. And our modifiable risk factors are going to be exercise and sleep, social engagement, education, and mental stimulation. Other issues you may see would be confabulation, and this is a term for creating stories in place of missing memories to maintain their self-esteem. There could also be preservation, that's the repetition of phrases or gestures long after stimulus is gone. Agraphia is the diminishing ability to read or write. Hyperorality, that's the tendency to put everything in the mouth. Aphasia, apraxia, or agnosia discussed earlier. And sundowning syndrome, which any of my nurses out there working night shift know exactly what sundowning is. And that's the tendency for the mood to drop and agitation to rise as the light of the day diminishes. It's very entwined with their circadian rhythm being thrown off, combined with the confusion of dementia. For our assessment, we're going to look at the memory impairment, initially for recent events, and then progress to both recent and remote events. It could also be disturbances in executive functioning, problem solving, planning and organizing, abstract thinking, and the diminishment of emotional expressions. The ways the memory can work with Alzheimer's patients can be bizarre sometimes. I remember many years ago when I was working as a paramedic, we had a baseball game on the radio on the truck while we were transporting an Alzheimer's patient. And I was talking about baseball with the guy. And he starts talking about this second baseman that I'd never heard of. After he got out, I looked it up on his phone, and yeah, he was talking about a second baseman for the Cleveland Indians from the 1980s, talking about the game like it was yesterday. It was, if we initially look at him, talk to him, he would have a full conversation. But once you got a little deeper in there, it just wasn't really making sense. For diagnostic tests, would be a CT scan, a PET scan, those mental status questionnaires with a mini mental state examinations, complete physical and neurological exams, complete medical and psychiatric history, and also reviewing those recent symptoms, medications, along with their nutrition. For our assessment guidelines, we want to evaluate current cognition level, identify and address any threats to safety, including at the home, review medications, interview family to assess preparation and coping, review available resources, and identify teaching and guidance needed regarding sundowning. Also, when reviewing medications, be sure to include any herbs, complementary medications. We want to make sure that everything is closely documented on the MedRec. That way we're ensuring there's no interactions that could be accounting for this sudden confusion. For our self-assessment, it's going to be realistic understanding of the disease, stress management, support and educational resources, realistic outcomes and recognition when they are achieved, and maintaining good self-care. Ellen continues, but then the next week I picked her up for a lunch date, and she looked really nice. No problem with that. She was all ready to go, but her house was freezing. I said, Mom, did you pay your electric bill? She just blinked at me. I don't know, she said. Well, okay, I said, let's see. Where's your checkbook? I don't know, she said. Just stop asking questions. I thought she was going to cry. Veronica tries to refer to the electric bill, but ends up saying, the invitation, the invitation. What is this a sign of? Would that be A, aphasia, B, apraxia, C, agnosia, or D, preservation? In this case, that's going to be A, aphasia, and that's that loss of language ability. For our outcomes identification, we want direct correlation of nursing diagnoses. We also want a plan to connect caregivers to support services. Also, providing that person-centered care and approach, health teaching and health promotion, and referring to community supports. Dealing with an elderly family member with dementia can be very, very difficult and extremely sad as well, especially in cases where they are forgetting their own children. It can be a very, very sad condition. It really takes a lot of empathy. The people working in elderly and gerontology do not get the recognition it does for how hard that field really is. There's going to be many different forms of community supports we could refer for this patient. Everything from transportation services, supervision and care when the primary caregiver is out of the home, referrals to daycare centers, information on support groups in the community, Meals on Wheels, information on respite and residential services, telephone numbers for helplines, and home health services. For our medications for cognitive symptoms, we could think of things like cholinesterase inhibitors, Exelon patch, other medications for the behavioral symptoms themselves. Though none are approved, the risk can be high, especially for antipsychotics used off-label with extreme caution. And remember, these are a last resort. They say that Haldol is completely contraindicated for the elderly, and that's for a very good reason. It increases the risk of dysrhythmias. And in the case of someone who's advanced in age, that risk of dysrhythmias increases a lot. But at the same time, when they are a danger to themselves or others, when does the risk outweigh the reward? When do the risk outweigh the benefits? It can really be a balancing act of, yes, there are some dangers of this medication, but they are also a major danger to themselves, others, and the staff. The cholinesterase inhibitors are indicated for mild to moderate stages of Alzheimer's disease, with the exception of donepezil, which is used for all stages, including severe. Continuing with our case study discussion, what are some appropriate community resources you could suggest to Ellen to help with her mother? And just as we previously talked about, transportation services, supervision and care when the primary caregiver is out of the home, referrals to daycare centers, information on support groups in a community, Meals on Wheels, information for respite and residential services, telephone numbers for helplines, and of course, home health services as well. Going on with some audience response questions. Acute onset of disordered thinking is most associated with A. Delirium, B. Alzheimer's disease, C. Frontotemporal dementia, or D. Dementia with Lewy bodies. And that answer here is A. Delirium. Acute onset and fluctuating levels of awareness are key findings in delirium. Your patient, 85-year-old Veronica, is diagnosed with Alzheimer's disease. What are some next steps you as her nurse can help with as both patient and family adjust to this news? 1. Evaluate the person's current level of cognitive and daily functioning. 2. Identify any threats to the person's safety and security and arrange their reduction. Evaluate the safety of the person's home environment with regard to wandering, eating edible objects, falling, and engaging in other dangerous behaviors. Review the patient's medications, including herbs and complementary agents, as well as over-the-counters that the patient is currently taking. Interview family members to gain a complete picture of the person's background and personality. Explore how well the family is prepared for and informed about the progress of the person's dementia, depending on the cause, if known. Discuss the family members how they're coping with the patient and their main issues at this time. Review the resources available to the family. Ask family members to describe the help they received from other family members and friends, as well as community resources. Determine whether caregivers are aware of community support groups and resources. And finally, identify the needs of the family for teaching and guidance, such as how to manage catastrophic reactions, changes in mood, aggressive behaviors, and nocturnal delirium, along with increased confusion and agitation at night. That sundowning we talked about previously. Veronica's Alzheimer's disease has progressed. One morning, she attempts to brush her teeth with a spoon. Which problem is evident? Would that be A. Aphasia, B. Apraxia, or C. Agnosia? In that case, then that answer here is B. Apraxia. This is the loss of purposeful movement in the absence of motor or sensory impairment. Could also be agnosia, as she's obviously confusing her objects as well. Alzheimer's disease can be extremely difficult and a very, very sad situation. You got to keep in mind these were strong, functioning adults who, unfortunately, through the natural changes, are slowly declining. And it's really sad when the mental faculties decline before the rest of the body. It can really be hard on the patient as well as extremely difficult on the family. You as a nurse, you really got to have a lot of empathy for this situation and do everything you can to support both the patient and their family. But anyway, that's all I've got for this chapter. I'll see you in the next slides.